Hello, everyone, and welcome to Africa Fire Mission's weekly virtual training session. My name is Mike. I'm a project coordinator here with Africa Fire Mission, and I'm so happy you all took the time out of your schedules to join us for today's training. Today, we're joined by Paul Marcolini. Hope I said that right. Paul's got a lot of experience in emergency medicine in areas where you may not have a lot of resources. He's going to be talking about patient assessment today. We're so happy that he's here today to join us. If you stick around today for at least 70% of today's training, which is usually about 40 or 45 minutes, you'll receive a certificate for today's training. Keep your eye down in the chat as well. I'll be posting some information there with a link to our Google folder where you can see today's training and any other training that we've done so far this year. And if you watch those videos, answer a few questions, you'll be able to receive a certificate of attendance for that training as well. When we complete today's training, we'll have tea time. It's your opportunity to talk about anything that's on your mind, discuss the topic of the day, or anything else. So I invite you to stick around for that as well. Normally we'd grab a word of encouragement from our fire safety advocate, Jose, but Jose is wrapping up some training yet today. So we're going to go right into today's training. I'm going to turn it over to Paul. Go ahead, sir.
Thanks, everybody, for having Howard Cohen, who some of you may know, reached out to me a little while ago to see if I would be able to step in and teach some of this stuff. And I was more than happy to do that, in part because I've actually spent a lot of time in East Africa working for the Outward Bound School, 5 years working on Kilimanjaro and teaching some medical classes in Tanzania, depending on where you are and how you pronounce it. So I'm really happy to be able to be engaged with you guys. So I live in northern United States. You can see the red on that in Vermont. But I also work in the state of Maine, which is one state over. So my background, I have been a paramedic for 15 or 16 years. Half of that time is spent working out of helicopters. I am also a paramedic for the National Park Service in the United States, and have worked a lot in Alaska. I came on to being involved in EMS by doing rescue in Niagara Falls in New York, and you probably all have heard of the falls. Well, there's a surprising number of people that actually fall in that gorge. And so I was doing the technical rescue and getting to these patients, and I knew how to get them out of there. And I had the technical skills to use the ropes to raise them, but I had no medical skills. And I was confounded by getting to these people and not knowing what to do. And so that started my pathway into emergency medicine to a level of paramedic here. I've also worked doing a lot of mountain rescue. So my skill set with patients is both in an urban city setting. Vermont's a very rural state, as is Maine. I have 2,000 people that live in the town that I'm in. So it's rural with very little resources, as is the state of Maine. So those are my two dogs down in that corner, and a look of what my house looked like a couple of weeks ago here in Maine with the snow still there. So what I want to look at in terms of a goal for today is just to take a look at a system for assessing a patient. And that's for both medical and trauma patients. And so our goal is to combine the subjective information, which is the story. So it's what the patient tells us. And one easy way to remember that is S for subjective, S for story. And so that's all the information they give us about the event. And so the question I ask myself when I come onto a patient is, how did they get there into that situation and why? And that's the subjective information. The objective information is what you find when you do your assessment. So it's when you touch the patient, when you do your physical exam on the patient, all of that information, including vital signs, is objective information. And so if you put the story together with your clinical findings, you end up with a problem list. And a simple way to think of the problem list is just what's wrong with this patient. And once you've identified that what's wrong, then your next step is to develop a treatment for that. So as an example, if we had a guy that was working on his house and was up 10 feet on a ladder, got stung by a bee and fell to the ground, and when his right leg hit the ground, he felt a snap or pop in that leg, that would be the subjective information. So our story is stung by a bee, fell 10 feet, felt a snap or a pop in his leg. And so those treatment plans would actually be two. One would be, do I need to treat the bee sting, and or just continue to monitor that patient in case he or goes into an allergic reaction from that bee sting, and then treat that fracture of that lower leg. You can't treat what you don't find. And so it's important when you start thinking about patient assessment that, you know, if we're really trying to help these people, if we're really trying to prevent death or further injury, we've got to do a complete survey on every single patient, a complete assessment on every single patient. And that's what we'll end up talking about here. So there are many patient assessment systems. I'm going to share with you one that I use. And the reason that I like this is that it's simple. It's a triangle, so each point of the triangle has something that you're supposed to be or should be looking for, and it helps us to guide us through determining what we need to do to help that patient. So the first is the scene size up, and that's basically stabilizing the scene. The second is primary or initial assessment, and when we get into it, we'll talk about looking at three body systems. So the circulatory system, the respiratory system, and the neurosystem. And that's all that we're looking at in our primary assessment. Then our secondary assessment is our more detailed hands-on assessment. It includes vital signs and some other things that we'll take a look at that help us to complete the picture in determining what's wrong with that patient. So let's take a look at these three triangles, and we'll break them out a little bit. So the first is scene size up. The three components to scene size up, we'll begin with risk. And the reason we start with risk is that, as you probably all know, you don't go into an unsafe scene unless you can stabilize or mitigate what that risk is to you. So as an example, in my wilderness medicine, I am not a very good paddler. I do not whitewater paddle. And so if my team was called to a whitewater emergency, I would not be the person going into the water. But if you were to call for a rescue on snow and ice, that's something that I've done a lot and I'm comfortable with, and I would go in. So, you know, when we're talking about EMS and we're talking about approaching a scene, the first thing we do is stop and make sure that it's safe for us to go in and go to work. That risk also expands into, is it safe for the public to be around in that situation? And then is it safe for the patient? And even though it may be safe for you to approach, may not be safe for that patient. And so you're going to need to work on getting the patient out of that situation. The opposite is also true. You might be able to see your patient, but it's not safe for you to access them yet. And so you need to wait until that stabilizes. So an example from a few weeks ago for me was responding to an automobile crash where a car hit a telephone pole, and the wires, the electrical wires from the pole came down and were laying across the top of the car. So in essence, the car was being energized by the electrical lines that was there. I did not approach that vehicle. I stood outside the vehicle and was talking or yelling to the patient, trying to get as much information as I could. But I did not approach that vehicle and put my hands on the patient until a power was cut to those wires that were on top of the tree. So that would be an example of where the risk of me going in, I would have become another patient after potential electrocution. So if it's not safe for you to go, you don't go. That picture of that automobile crash that's there shows what has been done to mitigate or prevent or decrease the risk. You can see the way the police car is parked and the fire apparatus is parked. They're blocking traffic so that the scene becomes safe for folks to work on the vehicle. So those are just a couple examples of risk. If we go up to where it says MOI in the opposite corner from risk, it gives us what the MOI is: mechanism of injury or mechanism of illness. And so there are 4 there. Trauma, which is the obvious one; medical, which might be respiratory distress or cardiac problems, heart problems, a heart attack; environmental, if we go back to the guy that fell 10 feet off the ladder that I just presented a minute ago, the environmental would be that bee sting. An environmental mechanism might be a snake bite. And then a mixed mechanism, a good example of that is also that guy off the ladder, because he's got an environmental mechanism, but he also has trauma from a fall. So there's times where we can break out this mechanism into 3 categories: trauma, medical, or environmental, if whatever is going on or happened to that patient is isolated. So if it's an isolated lower leg fracture without the bee sting, that's trauma. If it's just respiratory distress or heart attack, that's medical. If it's a snake bite, that's environmental. But many times they can be mixed. And so it's part of our job to figure out what's the mechanism. Once again, how did they get there and why? And that'll help guide our assessment as well as our treatment. Numbers of patients to numbers of rescuers. So it's not uncommon here in the States for me to respond with my ambulance and 1 other person. So if I get into a car crash, as an example, again, where there's been an automobile accident that's got 2 or 3 cars in it, and I've got 3 or 4 patients, that begins to overwhelm the resources. So we're early on, before we've even touched the patient, we're looking at the number of patients and the number of rescuers that we have, and then calling for more resources if we need them. So from a fire service perspective, we don't always roll an ambulance with a fire truck here, although some systems do. But it may be that if you're a firefighter and you're the first one onto the crash, if you have an ambulance available, that might be early on the time to make that call for extra help. It could just be that you need another piece of apparatus for more manpower or people power to manage a scene as well. So the scene size up, it's the risk to you going in. You need to protect yourself. The risk of you going into the patient. What's the mechanism? How did they get there and why? And then what do you have for resources? Do you have enough or do you need more? Within the scene size up is the personal safety aspect of it. So, but the big one with that, as I'm sure you're all aware, is body substance isolation. And so think of, if you're at a scene where there's a lot of blood or a lot of vomit, that you should have some eye protection, gloves and masks, which are pretty common throughout, masks particularly with all the junk we've gone through with COVID, and then protective clothing. The eye protection, the reason that that's important is if you were to be splashed in your eye with blood, that whatever bug that person or that patient has within their blood will be readily introduced into your body. The lining of your eyelids is a particular type of membrane called mucosal membrane that is readily absorbs any substance that comes in. You have the same membrane inside your mouth, and you may know of people that are having chest pain that get treated with nitroglycerin, either in the field or in the hospital. And that's just a small tab or spray that goes under their tongue. The reason it gets so absorbed so readily is that it's that same tissue. So eye protection might not be something that is high on your list, but in a situation where there's a lot of body substance, it should be. I think protective clothing, probably the fire service, at least in the States, does a better job with this than the ambulance does. From this perspective, when the fire apparatus rolls out, it has, with its firefighters, they're in their protective gear already. Not so much so with an ambulance. Typically when I'm working on the ambulance, particularly during the summer, I'm in a t-shirt and a pair of pants, and that's my protective stuff. So if I get on scene where there's an automobile crash again, I'm going to need to put some other protective clothing on, like firefighting gear, in order to keep myself safe when I approach that patient. Moving on to the primary assessment. So we've got the scene size up. We know how many people we need in terms of resources. We know what the mechanism is, and we know that it's safe for us to go up to that patient. So once we approach that patient, the first thing we'll do is a primary assessment or initial assessment. It also has 3 components and looks at body systems, the 3 critical body systems. So essentially with our primary assessment, we're looking at fixing whatever might kill the patient in the next short amount of time. So the way that the primary assessment works is, if you look at respiratory, the 2 components of respiratory are airway and breathing. So with this assessment, you're looking first at airway to see, do they have an airway problem, yes or no? If the answer to any of the questions in your primary assessment is yes, then you stop your assessment and fix that problem. So if they don't have an airway, it might be as simple as doing a head tilt chin lift to open that airway up. Are they breathing? And one of the things, at least in the States, that we have to look at now is, are they breathing adequately? So if you think of what a normal respiratory rate is, 12 to 20, if they're breathing, say 6 times per minute, that's not adequate. So if the airway is open and they're breathing 6 times a minute only, then we're going to need to support their ventilations. We're going to need to rescue breathe for them, either with a mask to mouth or with a bag valve device. The reason we see so much of it in the States right now is because we have such a prolific opioid problem. And it's not uncommon for, in services in my area, even in the rural areas, to run 3 or 4 overdose calls a week, where the patient presents with respiratory drive that's 6 or 8 from the use of that medication. So once again, the first step is respiratory. We're looking for, do they have an airway? Yes or no. Are they breathing adequately? Yes or no. If the answer is no, then we're going to breathe for them or increase their rate. If we look at circulation next, do they have a pulse? Yes or no. Are they bleeding? Yes or no. And this is life-threatening bleeding. It's not sort of, scrapes from coming off your bicycle on the road, sort of road rash kind of stuff. This is big bleeding. So when we think of that, we think of 2 types: internal bleeding and external bleeding. The external bleeding is usually pretty easy to see because you're going to see blood soak through the clothes, you're going to see blood on the ground. The internal bleeding is a little bit more difficult to find, but just as important. So the areas that we think of for internal bleeding are the chest, the belly, the pelvis, and each thigh. So when I'm concerned about external bleeding, in my primary assessment, I'm going to feel those areas to see if there's any indications for internal bleeding. So the way that I would do it with a chest is that it's difficult to have or to determine bleeding within the chest if you don't have a stethoscope. So if you're without a stethoscope, what I think of is, are there ribs that are fractured? Is there chest trauma, bruising, things like that that might indicate that there's some kind of injury that's underneath it. For the belly, it's questioning whether the belly is hard or soft. For the pelvis, it's putting your hands on the pelvis and pushing down to see if the pelvis feels stable. And for the thighs, it's feeling each thigh to see if it's soft and pliable, or is that thigh filled with blood to the point where the skin is tight, almost like a sausage would be. And so those are going to be my indicators for that internal bleeding. There's nothing we're going to do to fix that internal bleeding other than it being time sensitive and trying to get to a hospital as quickly as we can. For the external bleeding, we're going to stop that bleeding. And so that's a pretty simple thing to do if you can see where the source of that bleeding is, to put direct pressure on that wound. For our nervous system, the two components for that are spine and AVPU. Spine, what we're doing here is just asking ourselves, does the mechanism of injury, could there be a possibility that there's a spine injury? And if the answer is yes, the only thing we do in this primary assessment is to protect that spine, so to keep them from moving around. I'll talk about AVPU in just a second as a separate thing, because it's not something that, although in many systems it's common, I can't say that I saw it when I was working in East Africa much in terms of an evaluation. But essentially what AVPU is going to do is help us to evaluate the brain. So is the brain functioning normally? Yes or no? So to wrap this one up, the three parts of the primary assessment are respiratory, and the questions you're asking yourself is, do they have an airway and are they breathing adequately? It's circulatory system. Do they have a pulse and are they bleeding internally or externally? And then nervous system, it's AVPU, which we'll look at, and is there a potential for spine injury? The key to primary assessment is, if you find a problem, you stop what you're doing. You do not continue around the triangle. You stop and fix the problem. So here's what AVPU looks like. So AVPU is just a common way to describe mental status or brain function. So if I was to say to you, the patient is semi-conscious, well, that might mean something different to all of us. But if I said they're A on AVPU, which means they're awake, and then I say they're A on AVPU but confused, that gives you a good indication that's pretty straightforward for anybody to understand as you're working with other folks on the scene or passing your patient along to the hospital. So awake means what it says, and you can be awake and plus something else. So you can be awake and oriented, you could be awake and confused, you could be awake and combative, you could be awake and lethargic. So it's A on AVPU is awake plus something else. Verbal means, it does not mean that they're talking to you. What it means is, if you approach the patient and say, hey, can you hear me? Can you hear me? And you're doing it loud, close to their face. Can you hear me? If you can hear me, wiggle your fingers. If you can hear me, blink your eyes. So the picture I want you to have is that they're not awake. Their eyes are not necessarily open. Their eyes are probably going to be closed. You try to talk to them to determine that they're awake, and you're not getting anything back. When you ask a question, they're not answering it. The next step is to go to verbal, to shout at them, talk to them loud, ask them to wiggle their fingers or blink their eyes. They would be, if they're able to do that, then they're V on AVPU. If they're unable to, when you talk loudly to them, wiggle their fingers or blink their eyes, the next thing to check is to see if they're pain responsive. And so there's a couple ways that you can do that. One is to take your knuckles and swirl it on the chest, move it up on the chest, on the sternum, pressing hard to see if they grimace or if they move to try to draw away from that pain. You can also squeeze the muscles of the upper shoulder. The whole goal is to see if you introduce some pain, do you get a response to that pain? Then the last, so that would be P on AVPU, if that's the best you get. Or they're not awake, you can't arouse them with verbal stimuli, they don't arouse to painful stimulus, then they're unresponsive. So the key in looking at this is that as they go down from A, V, P, or U, what that suggests is that the brain is injured, and the more it's injured, so if they're awake and confused, there's something going on in the brain that's making them confused. But if they're unresponsive, that gives you more information. There's not going to be a lot that we do to fix it, but it gives us a benchmark so that as we continue in our time with this patient to reevaluate them, we know if they're getting better or getting worse. One of the things that I think is that I try to do when I'm doing all of my assessments is I'm looking for what's wrong, but I'm also looking for what's okay and what's right. I think that it can add to your own confidence, or I feel better when I can say, well, this is what's going on, but I've got, they're A on AVPU, so that's good. They may still have a fractured extremity. Not so good. That's going to be one of my problems, but I'm trying to sort of say, okay, some stuff is great, some stuff's not. Let's focus on what's not. Our secondary assessment has 3 component parts as well. And here the big difference from the primary is we're going to complete everything before we treat. So I'm going to go down and feel that guy's lower leg that fell off the ladder and acknowledge that there's an injury there, but I'm not going to stop what I'm doing to splint that right away. I'm going to finish my sample, my secondary exam, and then go back and splint that. So part of the reason you do a complete secondary assessment is to make sure you didn't miss anything in your primary. If, for example, you start to examine that leg, and as it is in New England here in the States right now, very cold, rainy day, maybe they had some rain pants on or protection from the weather. And when you initially took a look at it, you didn't realize that actually they're bleeding, but because they've got waterproof pants on, that blood is just pooling within those pants. So it gives you another opportunity to look for anything from your initial assessment that you may not have seen, but it also gives you the ability to go hands-on for your physical exam and start at the head and work your way down to the toes, feeling as you go along the way to see if you can discover any other injuries that may need treatment. So I kind of think of it like being a detective. And so you're presented with this person, and now your job is to figure out how did they get there and what needs to be treated. And that gets done through your physical exam. So it's hands-on, it's touching the body, it's going from the head, the chest, the belly, the pelvis, the lower legs, lower extremities. It's also checking the back. And so we're going to do a physical exam on everyone. Even if it's someone that's having a heart attack, I may do something with their chest where they say they're complaining of chest pain. I'm still going to touch or palpate that chest to see if I can make it better, make it worse. Does it stay the same? It's not going to help me to determine whether or not they're having a heart attack, but it gives me more information. And so I'm going to take that information and pull that into my treatment plan. Sample history and vital signs we'll talk about coming up. But one point I want to make as we go forward is that when I think of this exam, for someone that's a trauma patient, I'm going to do my physical exam, then do my vital signs, then do my sample history. Where if it's someone that's a medical patient, respiratory distress, asthma, a heart attack, you're going to get more information about what's going on with the patient by listening to their story, by going through with them and having an understanding of, so when did this chest pain start? How long has it been going on? What does it feel like? How could you describe it? And so for males, one of the typical, at least in the textbooks, one of the typical thing is they say like, well, it feels like an elephant sitting on my chest. So being complete in getting, in formulating your questions so you get as much information as you can. Is there anything that makes the chest pain worse? Is there anything that makes it better? So working along those lines to get a complete story, and then go down to my vital signs and then back up to my physical exam. So there's two pathways in this secondary. If it's trauma, you start with physical exam and go to vital signs. If it's medical, you start with the history and then go to vital signs. So you work your way around the triangle, completing all 3 points of the triangle, but you do that based on mechanism. It sort of guides which direction you work your way around the triangle. So you're going to get everything, all of the information, and then you're going to treat each of the problems that you find when you go, when you start your treatment for this person. As we're doing our detailed exam, I think a metaphor for it, or what I think about it when I teach this, is if all of you were getting ready this morning to take a plane out to fly to wherever, the pilot has a checklist that they have to go through. And so they go through every component of the aircraft and make sure that everything is functioning as it should before they take off down the runway. And that's kind of how I think about doing this physical exam. You need to be complete. You should do it the same each time. The order doesn't matter. If you started at the toes and worked your way up to the head, it doesn't matter as long as it's complete. So as long as the checklist has check boxes next to each of the areas that you're looking at, so that you're guaranteeing to yourself and your patient that the assessment is complete, that's what we're after. So within that checklist, as we inspect and palpate means touching. So how hard, for those of you that have not done patient assessments, how hard do you press down? Well, you press down enough to dent the skin. So it's not just touching the surface. You actually need to push on it a bit. And so what I think of is pushing down enough with your thumb or with your fingers that you're compressing the skin a bit. And when I'm doing that, inspect just means viewing it. So I'm looking at it and I'm touching it and I'm looking for, are there any deformities? So that lower leg with the guy off the ladder that I talked earlier about, let's say his fracture had his leg at an angle that wasn't normal. Well, that angle would be the deformity. So I think of also, as I do this, when I'm looking for deformities, the advantage when you do a patient assessment, particularly in somebody that's describing an injury for one leg or one arm, which are pretty much the simplest to do, is compare it to the uninjured arm. So if I'm not sure that that's deformed, just compare it to the arm that they're not complaining about and have, side to side comparison to determine whether there's a deformity there or not. Are there any wounds that you found that now need to be addressed? And these wounds may not be life-threatening. You found them on your secondary exam or your detailed physical exam, the third triangle. So it's not life-threatening bleeding, but it's still a wound and it may be seeping some blood. So we need to treat that as well. Discoloration is just pooling of blood under the skin. So think of a bruise. Is there swelling that's there? Are they tender? So here's one thing to sort of keep in mind as you go through it. If I tell you my leg really hurts, that's pain. But when you squeeze on it as my rescuer and I say, ow, that really hurts, that's tenderness. So pain is what the patient describes. Tenderness is what you find when you palpate or put your hands on that patient and squeeze when you do that assessment. Look for medical alert tags. That might be a clue as to how they got there. So someone that, as an example, is lying on the floor in an office building, it may not be, and they're unresponsive, it may not be that they fell. It may be that they're diabetic, which is a pretty straightforward thing for all of us to treat by simply giving them some sugars. If they're not completely unresponsive, but they're awake and confused, we can give them some sugar by mouth, just some simple stuff. And it may be just, drinking a Coke. So it doesn't need to be a sophisticated treatment. Are they on any medications? Now, one of the things that I think is difficult, this is something we all have to look for, because the medication that they're on may give us information about what the medical problem is. So the guy that is having a heart attack might have nitroglycerin as a medication, might have some other cardiac medications, and that's going to give us some clues. The problem with that is, as you probably are aware, there's a gazillion different medications out there. And there's no way, even as a flight paramedic, I can remember what all these medications are used for. So what I do, and what I might suggest to you, is there's a couple free drug programs that you can put on your phone. I can't remember them. I don't expect you to, but if I have a medication that I don't know, I just look it up on my phone to see what it's used for. And that's a way to gather that, because if I said the patient's on a nipramine right now, who would know what that is? Well, it's a behavior controlling drug. And the only reason I know that is I've had patients on it before and I didn't know what it was, so I looked it up. But if it was a new medication to me, a phone app is a great place to go, because you're certainly not going to know all of the medications that someone is on. Any other clues that's going on with the person? So anything you see that's a clue that's from the scene, so something you notice on the scene or something you notice on their clothing. So once again, I just recently worked an overdose call, so it's clear on my mind. Another clue was on the table where in front of where the person was sitting, there was a syringe and some other drug paraphernalia, and they had an altered mental status. So their brain function was down to P, and the respiratory rate was only 6. They were only breathing 6 times a minute. And that, with the clue of the drug paraphernalia, led me to say, well, we might have an overdose here, so let's treat it for an overdose and see what happens. And they, in fact, had overdosed and got better once we gave them the medication for that, the Narcan. So any other clues that you've got? This is where, once again, it's like being a detective, using as much information as you can get from the patient, as well as from your exam, from your assessment, to determine exactly what's going on. Blood pressures, you're probably all, vital signs you're probably all familiar with. And as I said, that's down in the bottom of the triangle. And so with trauma, you get to it early. With medicine, you get to it early after you've got the story. And with vital signs, what we're looking for is not one set, but several sets of vital signs. Because if you take one set of vital signs, it's like looking at a picture when actually we want to look at the movie. It's the trends over time that give us information. So pulse, respiration, blood pressure, you may or may not have a blood pressure cuff that you use. We can still get an idea of what blood pressure is by looking at pulse, respiration, and AVPU and mental status. And so if their pulse is really high and their respirations are really high, when they're complaining of abdominal pain from trauma, and their mental status is awake but confused or agitated, that might suggest that there's blood loss in their abdomen. So that's a life-threatening situation. If it's someone like most of you, pulses are variable. And if we were to take the pulse of most people in most of us on the Zoom call, there's going to be a huge variability. And so with pulse, it's kind of the reason we take it over trends is because we're looking for change. So, if you are a young woman athlete in really good shape, your pulse, resting pulse, your normal pulse might be really low. I have a friend that's an ultra marathoner, running 50 and 100-mile races, and actually was in the Olympics for, is a woman that I actually guided with on Kilimanjaro. And her resting pulse rate was 36, where if you took most of us in the room and put us at 36, we'd have an altered mental status because of a low pulse. So think of pulse as somewhere between 60 to 100 is norm. It's not hard and fast because everybody's different. So the number itself really doesn't make that much of a difference. The trend is what makes difference. Knowing that if someone is going into shock, true shock, their pulse is going to go up and their respiratory rate's going to go up. So if I just take one pulse and it's at 120, I may not recognize that. But if I take a pulse and 15 minutes later, I take a second one and it's now 130, 15 minutes later, I take it again and it's now 140 or 160, that gives me a trend that suggests that internal bleeding. Respiratory rate, once again, 12 to 20. But if every one of you went outside and ran as fast as you can around the building that you're in, your respiratory rate would be greater than 20, I'm going to bet. So we need to look at it within sort of the context or with what's going on. So if you ran around outside and you came back in and your respiratory rate was 30, that doesn't mean you're sick. It just means your respiratory rate is 30. But if you were complaining and had shortness of breath and had wheezes and your respiratory rate was 30, now I'm concerned, and I'm going to start to evaluate that more through the story to see if it's asthma, to see if they have their asthma medication with them. When was the last time they used their asthma medication? And so that's all in that sample history or the story part of the event. Temperature is core temperature. I can't say that I routinely do it. I mean, if you stop and think, and usually when I'm teaching a class of first responders, I'll ask how many of you have taken a rectal temperature on a patient in the last week. There's very few hands, if any, that go up. What we know is that what we're chasing with temperature, what we're looking for with temperature is extremes of temperature. So someone that's been outside in a hot sun all day and is no longer sweating and has an altered mental status, I might be thinking of a heat-related problem. So it might be worth taking a temperature. Conversely, in the world that I work in up in the mountains, where this time of year up in Alaska on the mountains, it'll be 30 degrees below 0 Fahrenheit, I'm concerned about cold injury. So temperatures plus or minus. I will say that with COVID, it is much more prevalent to take a temperature. I see them when I review run reports for the state, which is a job that I have, run reports of patient care from different ambulance services, that part of our requirement with the whole COVID deal was to obtain a temperature in the ambulance. That was in our protocols. So it gets taken a lot more. What I rely more on for temperature is the skin temperature. And that's no different than when maybe what your mom did. I know what my mom did when I decided today would be a good day. I didn't want to go to school. And I would say, Mom, I feel like I have a temperature, which usually was the ticket not to go to school. She would put her hand on her forehead and then touch my forehead and essentially do a comparison and say, you don't have a fever, get going, you're going to be late. So for the skin, I'm looking for color, I'm looking for temperature, and I'm looking for moisture. So to go back to a patient that's in shock, life-threatening, their skin color is going to be pale or grayish. Their temperature might be cool, and their skin's going to be moist. The reason their skin is moist is when in your body, it recognizes that you've got that bleeding going on, your heart rate significantly increases in order to pump whatever blood you've got left around to all of your vital organs. The drug or the drug within your body, I can't think of the right term, the drug within your body that mediates that increases your heart rate is adrenaline. And byproduct of adrenaline, of an adrenaline surge, is moisture. And, that happens in all of us in that flight or fight, or You may have been in a situation in high school where you were at a school dance and wanted to ask somebody to dance, and you were a little apprehensive of going over to them, but you're working your courage up, and all of a sudden you realize that your hands are a little sweaty and you're sweating a little bit. And well, with that whole adrenaline dump, you get moisture. And so that's where we see, or why we see moist skin on somebody that is in shock, but also somebody that's having a heart attack. Oxygen saturation, if you have the capability of doing it, that's what you see at a physician's office when they put the little probe on your finger and read that oxygen saturation. It's something that in an ambulance context we do. I can tell you that when I'm working with firefighters at an accident scene, that's not something they're necessarily doing, but it's more of a in an ambulance or in a hospital of kind of thing. And then once again, there's our level of consciousness. So your level of consciousness is a vital sign. So pulse, respirations are probably the two most important. Skin, and then blood pressure, temperature, and oxygen saturation are equally as important, but I think initially it's not something that we see being taken right away in the field. A sample history. So this is a breakdown of those questions from that third triangle, in part where you're trying to sort out the story of how did they get there and why. And that picture is just, I did a wilderness course for guides in the Serengeti. And we were working on litter carries and litter management, just practicing them. So symptoms are the first part. So what are they describing? My pain in my chest, I have a severe headache, whatever that problem is that they describe, that sort of group of symptoms. Any allergies that they have, and I'm concerned more about allergies like to bee stings or medications. I'm not as concerned to allergies of cat hair or dog hair, more things along the lines that would affect medical treatment. Any medications that they're on, any pertinent history that they've had. So someone complaining of abdominal pain, okay, so belly pain, but has had their appendix out already. And I know that from their history that they've told me, the probability of being in an appendix problem is very, very low. So it's going to give you some more clues. Last, ins and outs. One of the things in rural medicine, as opposed to being in an urban setting, in the urban city setting that I worked in, typically the ambulance was on scene after the call came in to 911 or our emergency dispatcher. We would average 6 to 8 minutes before we got on scene, and then another 6 to 8 minutes before we got to the hospital. So I was less concerned about ins and outs there. Where I live right now, it may take an hour to get to the patient in an ambulance. So when ins and outs look at when was the last time they peed, when was the last time they pooped, when, how much have they had to drink today, and when was their last meal? And what I'm concerned with about that is just making sure that they've got, if they're someone with a heat problem, when was the last time they drank? Have they been taking fluid in, taking water in, or some drink in? For cold problems, where they need to have calories to be able to shiver and warm up. So wintertime up here, I'm concerned when was the last time they ate? Because if they've used all their calories up already shivering, they may not be able to rewarm themselves. And I may give them some calories if they're awake to help them generate more heat. And then events, and the events are the story. How did they get there and why, once again? So it's whatever the story that they tell you that helps you to pull everything together. So SOAP note or documentation. I'm not sure what you guys do depending on your organization to document anytime you've had patient contact. In the ambulance service, we have to write a report up. And the report is called a SOAP note, but it looks at everything that we've just described. So it looks at what the story was. It looks at that sample history. your exam findings and vital signs, and your problem list, and then your treatment plan. The anticipated problems under assessment there is just you already know that they've got problem X. So let's say that guy with that broken leg fell from the ladder. Over time, that's going to swell. And that may lead to decreased circulation in that lower extremity because of the swelling. The blood vessels are just being compressed with all of the swelling. So when I think of my anticipated problems, I'm thinking about what's my anticipated treatment plan. So another example of an anticipated problem is someone, if we take the same guy off the ladder, but this time he hit his head when he went down. And he's now complaining of a significant headache. And maybe he has a laceration there that's minor bleeding that we have to control. An anticipated problem for him would be vomiting. Because if he really did hurt his brain, if he does have a traumatic brain injury, one of the early signs of swelling of the brain is vomiting. So I'm just thinking ahead, which is what that anticipated problems are. Thinking ahead, what else might be coming in my direction so that I can prepare for it as I treat this patient. I'm not treating for it right now. It's just sort of on my list of what might happen next. So I'm prepared to do that. One last example of that is I took a 8-year-old child out of that was burned significantly above his face, his hands, his chest. And one of my anticipated problems was that his airway might swell to the point where he was no longer able to breathe on his own. So I got out all of my equipment necessary to put an airway in this child. I never used it because he never his airway had not swollen that much. But I was anticipating it. If I had waited to the point or wasn't thinking about it, and I'm kind of behind the 8 ball now, I'm scrambling to find the gear I need and a plan for how I'm going to attack it. So anticipated problems are important. So where do you find the subjective history? That comes out of that first triangle. In part, it's the scene, it's the story. By looking at that scene, you're drawing some conclusion. So you come across a car accident where all of the damage is to the front of the car and the airbags have deployed. It gives you an idea, a rough idea anyway, of where some of the injury or what some of the injury patterns might look at. Objective are all out of that third triangle. Assessment is combining your first triangle and your second triangle to come and your third triangle, all 3 triangles, to come up with a problem list, and then a treatment for each of those different problems. So I want to thank you very much. I enjoyed being with you guys. I like sharing medicine. Is just, to me, it's so cool. It's kind of like ultimate problem solving. You're handed a problem and you got to solve it. And it's I just like being in that situation where you're really helping people on their worst day. And the way to be good at doing that is by going through those triangles and coming up with a problem list that makes sense, and then treating those problems. And what I want to do is just leave you with one other thought. And that thought is this patient assessment, it's a skill. And so on a Zoom, we're not able to put our hands on people and practice, but it's no different than any other skill you have either within EMS or firefighting. If you don't practice it, you won't be good at it. So I want to just encourage you to find someone, a family member or someone else, and practice that head to toe assessment. Start at the head, you're touching it, you're feeling it as you go down, you're looking in the eyes, you're looking in the ears, nose, and mouth, and we're working our way down the body looking for problems. Thank you.
Thank you so much, Paul. That was an awesome presentation. There's a few questions in the chat, and we're going to get to those in just a little bit. Before we do that, I'd just like to thank everyone for attending today. Remember, you can check out a replay of this video. It'll be posted either on today or tomorrow on YouTube, or check the link in the chat for our Google Drive, where you can see that and receive your certificate of attendance. We're going to carry on with tea time in just a moment. But once again, thank you, Paul, for coming. We're going to see all of you next week.
So Mike,